Welcome to this edition of Clinical Clips, an accredited continuing education activity. This brief expert video will spotlight the daily hot topics from the conference.
Welcome. My name is Dr. Jean Elwing, and I'm joining you here live from CHEST in Nashville on October 19th, the final day of this fantastic meeting. Over the last 2 days, I was able to attend several wonderful lectures and poster presentations. The first I'd like to mention to you is a session on healthcare disparities in pulmonary hypertension presented by Roberto Bernardo, Lana Melendez-Groves, and Vijay Balasubramanian. The panel discussed the significance of race, ethnicity, rurality, and social determinants of health in clinical outcomes in patients with pulmonary hypertension. They reviewed the needed steps we need to take to overcome these barriers. They noted that PAH has no specific treatment recommendations regarding race or ethnicity, unlike other cardiovascular diseases. The panel reviewed the REVEAL registry and how it gives us some insights into the demographics and common etiologies when considering race and ethnicity. White patients were significantly older than other races and ethnicities. Black patients were 2.5 times more likely to develop pulmonary hypertension associated with connective tissue disease. And congenital heart disease was much more common in Asians and Hispanics. They shared that race and ethnic minorities were underrepresented in all our clinical trials and registries. And these are the things that drive guidelines and current treatment. Black patients made up of only 2 to 7% of participants across all randomized controlled trials in pulmonary hypertension. Black patients only made up of 12% of the REVEAL registry population. And some randomized controlled trials don't even report information based on race or ethnicity in our patient population. The panel eloquently reviewed the multiple factors that can contribute to disparities in care. This discussion highlighted, so importantly, the great need for further awareness and action on this very important issue. An exciting poster presentation was given to us by Dr. Mark Simon, and it updated us on LTI 301 Inspire PAH clinical trial. This was evaluating inhaled treprostinil in a dry powder formulation. He reviewed data showing us that the dose response on walk distance and functional class was seen with this medication. Inhaled LIQ 861 had an incremental positive effect on 6-minute walk distance, with the median increase being 12.5 meters. And those who had low dose exposure of less than 79.5 micrograms only increased by 3.5 meters. But when you increase the dose to at least 106 micrograms, you had a median increase of 14 meters. Additionally, he reviewed results showing us that individuals that were exposed to at least 79.5 micrograms improved their functional class. Additionally, he reviewed results showing us that those individuals who received at least 79.5 microgram dosing improved their functional class from baseline. At baseline, 61% were functional class 2 and 39% functional class 3. And that improved to 10% functional class 1, 65% functional class 2, and 25% functional class 3 at end of study. Dr. Jim White also presented some very interesting data from Freedom EV open label extension. Freedom EV was the parent study that looked at oral treprostinil and enrolled 690 patients and showed delayed in clinical worsening when patients received active therapy. Patients who experienced clinical worsening or those who completed Freedom EV could roll into the open label extension. 470 participants enrolled in open label. Survival was evaluated over the entire study period of EV and open label. And it was shown that oral treprostinil was associated with an overall 36% risk reduction of death versus placebo at study closure. When Freedom EV participants were evaluated, the baseline risk status of both groups were assessed, and the participants who received active medication in Freedom EV actually had higher risk scores as compared to the placebo counterparts. They had a higher REVEAL Lite 2 score and a higher Compara score. Despite this higher score, Participants who received oral treprostinil in Freedom EV had lower mortality at end of study. The number needed to treat to prevent one death was 11.8, and the absolute risk reduction in total known deaths was 8.5%. Data from the INCREASE study was also presented. The INCREASE study evaluated patients with pulmonary hypertension and interstitial lung disease. This study met its primary endpoint of improvement in 6-minute walk distance when patients were treated with active inhaled treprostinil. Patients who completed this study were eligible to enroll in the open-label extension. The INCREASE open-label extension post-hoc analysis was presented, evaluating the effect of treatment delay in participants with less severe hemodynamic impairment. This included patients with PVRs less than 5.275, median baseline mean pulmonary artery pressure of less than 35, and those with NT-proBNP less than 528, who were treated with inhaled treprostinil. Each of those groups were evaluated. The participants who were exposed to active treprostinil in the parent study and then enrolled in the open label were compared to those who received placebo initially. In each group, the participants who received initial placebo experienced a decrement in their walk distance during the randomized controlled portion of the trial and did not improve their walk distance to the level of those who received active medication in the parent study. This raised concern for a lack of catch-up in those who had delayed to active therapy. Additional data from the INCREASE study was presented related to its effect on NT-proBNP. Those individuals who were exposed to active treprostinil in the INCREASE trial had a decrease in their NT-proBNP in the randomized controlled portion of the study and a further decrease in the open label. Those individuals who initially received placebo had an increase in their NT-proBNP during that time, and then a decline once they received active medication in the open label extension. These were just some highlights from our meeting. Thank you so much for joining me today live from CHEST here in Nashville. We had an incredible meeting and a great educational experience.
We hope you found this activity useful and educational. To receive continuing education credit and to download your printable certificate, please return to the activity webpage and click on the Claim Credit button associated with today's clinical clip.